My name is Larry Ver Hoef. I'm an associate professor in the Department of Neurology here and a member of the UAB Epilepsy Center. I've been at UAB since 2000 and been on faculty since 2005. I'm an associate professor and I'm the associate director of the Epilepsy Division and the director of the Epilepsy Monitoring Unit at UAB Hospital. Well, the UAB Epilepsy Program is the only Level 4 epilepsy center in the state of Alabama. Level 4 Epilepsy Center designation means that we offer a full range of services, particularly including the Epilepsy Monitoring Unit, as well as full epilepsy surgery evaluation. So we offer a comprehensive evaluation for epilepsy surgery, which includes a full range of diagnostic testing, including advanced epilepsy-specific MRI protocols, PET imaging of the brain, magnetoencephalography, ictal SPECT, neuropsychological testing, and a full range of surgical options as well. Our mission at the Epilepsy Monitoring Unit is to serve the patients and the physicians in the state of Alabama and the surrounding communities as a resource for expert epilepsy care, both in terms of management and diagnosis. When patients are referred to the Epilepsy Monitoring Unit from, let's say, a community-based neurologist, they will very often see us in parallel with their primary neurologist. And this is an excellent way to care for things. Many of our patients come from as far as 4 hours away in all corners of the state, and it's good for them to have a local neurologist. I think it's important for the physicians in the state of Alabama to know that we are very pleased to have them refer their patients directly to our Epilepsy Monitoring Unit. Some of the other centers nationwide, many of them insist that patients be referred initially to see one of the neurologists in the clinic, only then to be referred into the Epilepsy Monitoring Unit. But we really feel that it provides better and more expeditious care for our patients to allow the physicians, our partners in the community, to refer the patients directly to the Epilepsy Monitoring Unit if they deem that it's appropriate. There are several reasons why a patient might need to be admitted to the Epilepsy Monitoring Unit. First and foremost, to make a definitive diagnosis. This is very important because it turns out that about 40% of people who have seizure-like events turn out, in fact, not to have epilepsy. And admission to an Epilepsy Monitoring Unit may be the only way to make that diagnosis definitively. Second reason would be for characterization of the epilepsy syndrome. The two main forms of epilepsy, speaking very broadly, are generalized epilepsy, in which the seizures start all over the brain at once, and focal epilepsy, which is where the seizures begin in one specific spot. Again, monitoring the Epilepsy Monitoring Unit can clearly differentiate between these two forms of epilepsy, which may guide both medical management and potentially surgical management. That leads us to the third reason for admission to the Epilepsy Monitoring Unit, which is part of a pre-surgical evaluation. This is an absolutely essential step to evaluating somebody for epilepsy surgery because we need to see where in the brain the seizures are originating, and this is important both to look at the EEG, or the brainwave activity during the seizures, as well as the video of the physical manifestations of the seizures. The last and probably least common use for the Epilepsy Monitoring Unit, but an important one, is that there are sometimes when patients whose seizures are so difficult to control and their epilepsy is so severe that switching their medications from one medicine to another really can only be safely done in the context of continuous monitoring. And so sometimes we'll admit patients to the Epilepsy Monitoring Unit so that we can do a rapid transition of their medications. The evaluation of an epilepsy patient, first and foremost, begins with getting a thorough, detailed history. Unlike a lot of neurologic conditions in which the physical exam tells you a lot of the story, in epilepsy, most of the patients are completely normal when they're not having a seizure and have no abnormal physical exam findings. So the history is really the most important thing, getting a detailed story of how the seizure begins, how the seizure progresses, what the patient is like after the seizure. So the devil's in the details, really, of getting the history. And it's very important to get an eyewitness history. So I always insist that the patients not come by themselves, but that they come with somebody else who has witnessed one of the seizures who can tell us what's going on. In particular, at UAB, we we have a special epilepsy protocol where they get an MRI scan that has sequences that are tailored to show us the types of abnormalities that are common in epilepsy patients, and they're reviewed by a neuroimaging expert who is experienced in treating and evaluating epilepsy MRI. The other main pillar of our evaluation is the epilepsy monitoring unit. So we have an 8-bed epilepsy monitoring unit here. We are able to bring patients in and record them 24 hours a day for several days to try to capture some of their seizures and see exactly how their brainwave activity changes throughout the seizure. This helps us then localize where the seizures are coming from and choose the best treatment plan for them. The evaluation of the epilepsy patient is done primarily by the neurologist. However, when a patient is considered to be an epilepsy surgery candidate, then we take a multidisciplinary team approach that includes a neurologist, neurosurgeons, neurology nurses, a psychologist, neuroimaging experts, and a clinical neuropsychologist. And so we take a team-based approach. If we then do decide to go to the operating room, that decision is only made in a group setting with everyone giving opportunity to provide input. So the decision is always a consensus decision and never made just by one individual. We tailor all of our evaluations very specifically to the individual patient and consider every patient to be unique. At UAB, we have several advanced testing modalities. A WADA test is one of them. What a WADA test is also known as an intracarotid amobarbital test. The patient receives a catheterization, an intraarterial catheterization, and in this procedure, what we do is we actually put half of the patient's brain to sleep while the other half is awake. At that point, then we administer certain tests to see what their motor functions are, what their language functions are, and what their memory functions are. Then the patient is allowed to recover from that, and then we put the other half of the brain to sleep to see what the functions are of the other hemisphere. What the WADA test really does for us is it helps us assess both what part of their brain or which side of their brain controls memory and language. It also helps us assess what is at risk for surgery. That's an important part of the epilepsy surgery evaluation, is what's at risk if we do operate on one side of the brain or the other. An MEG stands for magnetoencephalography. Okay, this is conceptually similar to an EEG, which is an electroencephalography, except instead of putting electrodes on the scalp and recording brainwave activity directly from the head, a magnetoencephalography measures minute fluctuations in the magnetic field around the head that emanate from the brain as a result of the electrical activity in the brain. This is perfectly suited for detecting epileptiform activity and epileptiform spikes that are coming from the part of the brain that are causing the patient's seizures. This is something that is very unique at UAB. We are one of the only centers in the Southeast and definitely the most active and have the longest history of having MEG in the Southeast. So while we certainly refer a lot of our patients from within UAB to get MEG, most of the patients getting MEG are actually from other academic epilepsy centers. They're referring them here. We had patients from Duke University, from Vanderbilt, from the Medical College of Georgia, and even as far away as Florida. Another test that we can offer is a test called ICTEL-SPECT. What an ICTEL-SPECT involves is a patient gets admitted to the epilepsy monitoring unit, and a nurse sits at the bedside waiting for the patient to have a seizure. When they have a seizure, she then gives them an injection of an isotope. This isotope then gets absorbed in the part of their brain where the seizures are coming from. And it really just gives us a snapshot of what the blood flow in the brain is during the time that somebody is having a seizure. And then what we can do is follow that up a couple hours later by getting a nuclear medicine scan that shows us where the isotope is located, and from that we can deduce where the seizures are or hopefully we can deduce where the seizure focus is emanating from.